Introducing our today's eminent and dynamic speaker, Dr. Mohammed Elnim is a respected senior clinical pharmacist educator and researcher with a high academic journey spanning higher education institutions in Saudi Arabia, Malaysia, and the United Kingdom. Dr. Elnim currently serves as a lecturer in clinical pharmacy in Ulster University, where he specializes in the quality use of medicines, digital health, health service research, and pharmacy education with a strong and growing publication record in internationally recognized peer reviewed journals. His work has significantly contributed to advancing pharmacy practice and education on a global scale. He is a member and fellow of several prestigious institutions, including the Higher Education Academy, the Royal Society for Public Health, the Royal Pharmaceutical Society, the International Diabetes Federation, and the International Pharmaceutical Federation. Beyond his academic and research excellence, Dr. Elam also serves as the editorial board of several leading pharmacy journals where he plays a key role as an associate editor, reflecting his commitment to the dissemination of impactful scientific research. His professional journey is marked by strong leadership in international research initiatives, a passion for innovation and collaborative scholarship, and a steadfast dedication to improving healthcare outcomes through better pharmaceutical care. So, everybody, please show your reactions down below and in welcoming our super dynamic speaker, Dr. Mohammed Elnam. Welcome, sir. Thank you so much for joining us, and you can take on.
Oh, okay. Thank you. Thank you very much for the kind invitation in the very beginning and also for the very nice and comprehensive introduction. Thank you so much for this. Happy to be with you and spend this maybe afternoon here and evening, I think, in India. Today topic is all about case-based learning. Case-based learning. We'll share my slides in a few seconds first. Okay, hopefully I because I cannot see the Microsoft Teams during the presentation, so perhaps if anything, just let me know. Hopefully you can see the slides and also you can maybe hear me clearly. If anything, just maybe write on the chat or interrupt me, no problem at all. Okay. First, our today topic, as I mentioned, it is all about case-based learning. We'll discuss from the interest point when it comes to solutions to common challenges and how case-based learning actually could help to provide some solutions to common challenges in practice and education related to the clinical pharmacy. So our session objective or the main objective will be centered around just case-based learning in the very beginning, what definition, principles of defining case-based learning as a pedagogical strategy and pharmacy education in general. Also, we will talk in the second section about general challenges and how case-based learning could be something relevant to help us to address several challenges. Also, we will delve deeper to highlight some specific patient scenario or specific cases when it comes to medication without harm initiative and how case-based learning actually can be designed in a way to serve specific certain clinical scenarios. And toward the end, from educator point of view, and from those of you who want to implement this one in their practice, what could be the key consideration to design CBL in general, and also how can use the generative AI to maybe to harness a process and make it even more easier and effective. Okay. Could you please try to join this one? I just couple of questions at the very beginning. I will ask you just couple of questions to just understand the audience. So if you can scan the QR code, or if you go just vivox.app and enter this ID, will be more than enough. Will be just perfect. Okay. If there anyone has any problem to join, I will just straightforward go to the first one. You can see still, I think the code for joining is still on the top. Okay, if you want it back, it is here 156509997. 156509997. Okay, the first question is, did you have any experience with CPL in education, in practice? Yes or no, just as simple as this. Is the poll accessible? You can see the question at your side or not?
Sir,
Is there
actually, we could see
anyone?
the question. If it is better for us to comment in the comment section, and I will tell you what the responses were. It will be easy for us to make it in a short span of time, sir.
No problem. No problem. No problem at all. If you want, just to straightforward in the chat box, okay. If you want to put your answer here, also okay. No problem. I can also have a look on the chat box. Okay, yes. Is it one yes so far? Okay. Oh, okay. No problem. We move on. We'll move on. And no, yes, and no. Describe in few words. There is no problem. Yes, no, 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 no. Okay. That's no problem. More notes are coming in. That's lovely. No problem. No problem at all. Okay, so I will start first by the introduction. Thank you everyone for the getting back to me with this feedback. The case-based learning as introduction in the very beginning. It is a kind of learner-centered or student-centered all the time. It is based on a case or query or certain questions within a case scenario. So it is inquiry-driven pedagogy. It is built all the time on retrieving realistic patient scenario that if in education, for example, we have some scenario coming from practice, from hospital setting, from community pharmacy, from GB pharmacy, whatsoever. So it has to be some realistic patient scenario to serve certain learning objective within the design itself. It facilitates, of course, critical thinking and decision making all the time, and help in educational setting to bridge a gap between the theory and real world practice. If we want to more maybe context of the case-based learning, as I mentioned, it is student-centered teaching model, express students to real-world situations, cases in the very particular. They must answer to achieve certain maybe learning outcome, and throughout the journey, answering the question, they build on some clinical reasoning skills and also utilize practically their therapeutic knowledge or the theoretical knowledge they have maybe in pharmacotherapy or pharmacology, whatsoever. So when it comes to the key benefits in the pharmacy education, of course, serve sometimes maybe foster the critical thinking, bridging gap, of course, theory and practice all the time, promote collaborative learning. Most of the time, the case-based learning will be based on a group. So different group will give in different cases and they work on the case as a group. So that some sort of collaborative learning can be built on as well. Improves academic performance, and I will show you some evidence later on. And also the clinical reasoning and clinical decision making skills also tends to be developed and improved by this strategy. So we are talking about certain instruction approach that we can use the patient cases, the realistic patient cases, to promote application of knowledge and skill in the pharmacy education in general. We have evidence, as maybe I give you at the end some further reading and evidence. One of them is a meta-analysis of 21 studies that show us it's really helped to improve academic performance and ability to analyze and maybe handling complex cases compared to traditional methods like lectures and all this stuff. Okay. So if we want to maybe to summarize why case-based learning is something important in pharmacy in general, so we will maybe highlight first, it has improve and develop some analytical skills when it comes to critical thinking. It really improve problem solving. Most of the time we have the case with certain questions, so you think about everything in the case while considering or making recommendation on certain aspect of the clinical care for this particular patients. It helped to apply knowledge to real world scenarios, integrate knowledge and connect with clinical practice. And this in clinical pharmacy, of course, it is a fundamental most of the time to make the teaching relevant to practice. So case-based learning of one of the very important modality to help bridging this gap. And of course, encourage collaboration. We attend lecture, everyone on his own, everyone may be sitting and handling and thinking about the content on his own. But when it comes to CPL, when it comes to case-based learning, we have to work together where everyone has to contribute and to help address the scenario and the cases in a sequence. So this, I think the first part, so the CPL or the case-based learning in general, just it is a method in teaching or a method on maybe offering the clinical pharmacy teaching or clinical pharmacy education, building on real world case scenarios, different scenarios. You have the ability actually to design the scenario in a way that serves certain learning objective. It can be applied to different topics, and I will show you now maybe how from a general and a specific perspective we can work on CPL and make it relevant to education and practice. So the second point, or the second section of my talk today will be the general challenges. Of course, in clinical pharmacy, I think this global, but you will see some UK-based references, but I believe this global challenges in clinical pharmacy everywhere when it comes to workforce shortage or workforce maybe a related problem with workload and all this one, financial pressures and underfunding for certain services or certain schemes, increase number and complexity of medication offered and treatment plan. When it comes to information resources, also we have too many disparate information resources are available per country and global as well. We have medication error and patient safety concern, and we will talk about this one later on. We have also the pharmacists themselves, the service provider and how their well-being when it comes to mental health and burnout and all this one. So these challenges in general can be to some extent when it comes as an educator to think of course, you can help to address some of these challenges through innovative educational approaches. One of them will be maybe the CPL in general. Okay. For example, actually, when it comes to information overload, so many medications, so many information, so many points to think of. So as a pharmacist or as a practitioner, you may sometimes got distracted or maybe struggle with too many resources here and there for information, retrieving patient education, looking for drug interactions, and looking for maybe resources that be tailored or customized for certain clinical scenario. All this, to some extent, also can be served or can be resolved using the case-based learning. We structure some cases, teaching information, filtering, and critical resource evaluation. We have maybe in certain designs in the OSCE we conduct here, we have certain stations around medicine information, how actually the drug information skills or medicine information skills, the accuracy, the timing, and all this one could be developed. So case-based learning is something could be very much helpful in this context. You can think of developing case requiring evaluation, multiple information, teach efficient search strategy, and sometimes reflection on accuracy of certain cases as a debrief after the discussion. So the information overload can be addressed to some extent. More importantly, will be the medication error. We know medication error is a global problem. It is not maybe confined to certain country. It is a global issue, and we have the WHO report on medication without harm. And in 2017, we have the patient safety global challenge. We have all this information maybe indicating the burden of medication error. And I think this is very much, again, relevant to be addressed by case-based learning through cases built around error identification and prevention through realistic case scenarios, where could be the source of error. And I think now in the literature, we have extensive resources for even sometimes medication, what kind of medication error could happen from this particular medication and how to avoid them. When it comes to implementation strategy, we can develop case based on common error pattern. For example, insulin. What common error could be happen while dispensing or dealing with insulin? So we have some resources on this one. So we could build what kind of error could happen with changing brand to generic or whatsoever for anti-epileptic drugs, for example. All this data also could be developed, and it can be easily developed as a case-based learning to address the medication error from this particular problem, helping the learners or helping the students with error identification and ensuring the patient safety all together. The last one in the general challenges as well, I think this again relevant to all settings. I think at the global stage, we have now more complex patient population. We have, of course, elderly population growing everywhere. We have also some special population when it comes to pediatric. We have some age-related pharmacokinetic changes happen. This could be different from one medication to another. We have, of course, polypharmacy. I will talk about this particular point later on. We have, of course, more cases presented with multiple morbidity. So we have a range of diseases all together. We have currently many medications that target more than one particular key indication. So we have how to use this medication together and how to make the most and in a safe and optimal way for the case we are handling. So the case-based learning in this context will be some sort of showing the diversity in the patient population we have, showing how complex and diverse the patient scenario, so we can develop elderly case, for example, focusing on the polypharmacy and stuff. We developed some dosing related queries in a pediatric case and how to adjust and handle or titrate up a dose for a pediatric case. We can, in between the patient with multiple comorbidity and how to handle maybe diabetes with some renal insufficiency and some other problem. So how to handle all this together, I think, will be very much this. It could be at the core, actually, of the case-based learning in a given sense. So implementation, we can create featuring diverse cases, diverse maybe even the patient scenarios can be different, comorbidity can be different, and also handling and refining the communication skills needed for every particular case. These are challenges in general, as I mentioned, and how case-based learning could be helpful. We will move further to be more specific and try to narrow down what could be the specific challenges that can, to some extent, also resolved by using case-based learning. For example, as I mentioned in the very beginning, We have polypharmacy and multimorbidity. This a common challenges seen everywhere. We have antimicrobial stewardship and the points related to optimal use of antimicrobial. I think this also relevant to some extent. We have a range of high-risk medication identified by the WHO. One of them, for example, will be anticoagulant or sometimes antipsychotics or insulin and all this stuff. Also, we have cases when we have transition of care, patients from home to hospital, from hospital to home, or from hospital to some other different level of care. So transition of care and how the discrepancy and lack of proper communication can cause sometimes problem. So if we want maybe to briefly go for the challenges one by one, we have the polypharmacy. Define the most common definition will be 5 or more medication, concurrent medication in seen most of the time in elderly patients. Our problem with the polypharmacy will be increasing risk of course, the adverse drug reaction and at the same time, we start the struggle with adherence of all this medication together and the hospital admission later on. We have many guidance, and here in the NICE where we have guidance on consideration for medicine optimization. So this also could be one of the interesting points in looking at this challenge in general. In reality, you can many times you can see cases like this. It is not 5 medication. You can see cases, for example, if they have 3 comorbidities like heart failure, maybe type 2 diabetes, osteoarthritis and stuff. You can see patients on regular 10 medication all together. The patient is relatively elderly or older adult, as we tend to refer to them. Current complaints and the risk they have, dizziness and falls, and this very critical at this age group, and have also some recent admission for hypertension. So here you can use this very general information and construct and develop a comprehensive case scenario with questions to handle or to refine clinical reasoning and critical thinking for the students across all this particular point. The solutions or the points you can use from case-based learning when it comes to polypharmacy, one will be how important the medication review and how important to use tools for assessing how optimal the need for this 10 medication. We have stop-start criteria. We have maybe medication appropriate index. We have so many tools in this context. So being familiar with medication review template, how actually I go and assess the need of every individual medication, this also can be interesting points. When it comes to medication assessment, whether this medication is needed to continue or this medication can be stopped or can be, as we see, can be deprescribed this medication. How to assess this decision? We have clear deprescribing algorithm, so we can go through them step by step in the case-based learning, and also after making certain decision, how to make sure this decision was the right one, or maybe perhaps something else should be considered first. This monitoring and follow-up, and maybe seeing the case over a few days will be also something very visible we can do in the case-based learning design. So this, I think, the first one related to polypharmacy. When it comes to the second one, antimicrobial stewardship, we have, of course, a global challenge of the AMR and the antimicrobial resistance, I think, everywhere again. We have struggles, I think, when it comes to inappropriate duration and dosing sometimes, beyond the selection even. So the selection sometimes has a problem, but duration and dosing most of the time have the most problematic scenarios. We have also a concern of those patients need long-term antibiotic, but without need of staying in the hospital. So we have outpatient parenteral antimicrobial therapy, the OPAT, and how complex and how this one can be optimized. So a case like Mr. Khan, for example, he should be discharged from the hospital in cephalic zone for number of days and OPAT service. He has currently no renal function assessed or monitoring at all. So in this particular scenario, as simple as what could be the principle, the guidance we have, for example, NICE NG15 compliance, this a guidance covering all aspects when it comes to antimicrobial stewardship, the system and process for effective antimicrobial medicine use, and both effective and maybe the safe and effective should be considered at the same time. Pharmacists, how the pharmacist-led IV and oral, we have protocol for this one, a hospital and trust-based protocol for pharmacist-led IV to oral switch protocol. If I want, for example, patients in IV medication will be switched to a comparable medication, oral, how this switch happen. And if the same medication does not have oral comparator and we want to maybe to continue on at home, so have to initiate OPAT service and who will look after the protocol and everything has to be there. The audit and feedback, of course, to prescriber on the prescribing pattern is fundamental. Patient counseling or red flag, when actually the patients can maybe recognize this could be a red flag and I need to go back to the hospital, I need to seek maybe further care. So red flag symptoms based on every particular infectious disease also should be identified and maybe educated to the patient. The third challenge, specific challenge also, the case-based learning could help with medication like anticoagulant. We have the direct oral anticoagulant. Their dosing, for example, should consider weight. Sometimes it should consider renal function. And sometimes the patient start on warfarin, want to dabigatran, or start warfarin, want apixaban. How to transition between this medication to another one? We have, of course, in the literature, there is clear and protocol on this one. How to assess bleeding risk stratification. Of course, the major risk of using anticoagulant will be the bleeding, but at the same time, they are very crucial when it comes to prophylaxis, certain points like stroke and stuff. So Mr. O'Connor, for example, will start right now. His creatinine clearance is 28 milli per minute, and on apixaban 5, he starts to report epistaxis and concurrent non-steroidal use. So in this case, how to think about, because we have declining renal function, we have anticoagulant in a way, we have the patients, some sort of start bleeding symptoms to take place. We have concurrent medication that can increase bleeding risk. So what could be the solutions in this particular case? And I think the solution will be something related to stressing the use and the function of having bleeding risk and the risk and the assessment for bleeding risk and assessment for the anticoagulant benefit at the same time using this particular tools. We need to look back for the medication specific renal adjusted dosing. We need, I think it is maybe here in the UK, I think I found in Malaysia, I think perhaps in India, you have similar model perhaps when it comes to pharmacists run anticoagulant clinic. So the pharmacist will look after in all the details related to anticoagulant and all other medication, and even maybe go extensive to see the dietary plan and all the patient's other details that can interact or can overlap with the action or how effective the anticoagulant in this particular case. And how to recognize and report the ADR in a given case. The last specific challenge in this particular context will be the one related to transition of care. We have some data that show that 30% of the medication error could happen at the stage while the patient is transitioning from, for example, discharged from hospital to home. So at this point, at the point of discharge, some medication will be stopped, some medication will be put on, and some of this medication was not there before the patient come to the hospital. Who will take care about maybe reviewing all this medication altogether and ensure that the medication plan that the patient discharged is the same intended one, and the patient is fully understood what's going on with his new medication, if any. So we have problem with incomplete discharge summaries. We have problem, of course, of communication between different level of care. For this particular one, we might have a patient like maybe a very young pediatric patients, have some anti-epileptic drugs are going on. The exact dose has not been communicated to the primary care or the general practitioner looking after. And later on, the same patient readmitted with breakthrough seizure. Breakthrough seizure means maybe a complication of a poor controlled epilepsy. So in this particular scenario, the solutions could be something related to what could a pharmacist do when it comes to medicine reconciliation within 24 hours from discharge, how we can, and I think in all setting now they are heading toward this one, how electronic transfer of medicine information could happen rather than the patient take a letter from there and go another level of care and handing the letter, and the letter could be missing here and there. So this all data, I think here in the UK and I think many other countries as well, they have also this electronic link. So whatever updates happen will be at the time, at the moment, will be transferred and reflected for your prescriber at the hospital and GP and whatsoever. Teach back counseling and written plan to ensure that the patient is well informed about all the details, and of course follow up calls within 48 hours post discharge to ensure that everything in place. This could all be designed as maybe case-based learning. The last section in my talk today will be around, okay, if I was successful enough to convince you that case-based learning or CPL is something good to consider, okay, how to efficiently design and how to use generative AI, by the way, to in this design. So embedding CPL and case-based learning in curriculum and practice could be sometimes many lecture and small group cases, can be virtual patients in certain cases, escape rooms, and all this one become very popular now as a gamified way to ensure problem solving, teamwork, critical thinking all together. We can have some sort of assessment like maybe template like SOPNOT, MCQs, reflective journal, and all this one. If you want to step by step, I think, as I mentioned, we have many scenarios can be served by the CPL. So first of all, just be mindful what core competencies you want to address, how to map this competency to curriculum phase, develop a case library and real-world scenarios that you have, train facilitators, because this session has to be maybe facilitated and delivered by people who may be well educated and well experienced in CPL pedagogy in general. Implement the session and assess learner feedback, and you find cases again and again. So implementing in practice, so first decide what needs you have. So the needs assessment, what is specific challenge? I want to do something related to antimicrobial or polypharmacy or anticoagulant or something else, or multimorbidity in general. So needs assessment, what kind or what domains you want to address. Work on developing the case, and there are many resources can help with this one. Rely on authentic cases, and authentic cases coming from practice, and you can help later on to develop by generative AI. I will show you later. And facilitate the facilitator training, train people who will deliver the session, and integrate the activity and evaluate later on. It kind of very much advisable to use mix paper and online and simulation cases. You can incorporate peer teaching in some questions on some aspect of the case. We can actually ask one of the students to maybe to elaborate certain concepts to others. So peer teaching and collaborative learning, they work together on addressing certain query will be really helpful. Include some reflection components to consolidate learning. I think this reflection could happen after every query or after every question in the case, or as a debrief, as I will show you later. Align cases with current practice guidelines and evidence. This will be very much important to consider. If a guideline has been updated or something, make sure that the case-based learning reflect the updates and highlight what actually how these updates can reflect in clinical decision making and also in handling the case. So as a tips for effective case-based learning facilitation, you can start with clear learning outcome. So today our learning outcome could be 1, 2, 3. If it's polypharmacy, so we want to highlight maybe something related to extensive or complete medication review. What are the tools can be used and all this one. So clear learning outcome is maybe a fundamental. Provide progressive disclosure of data on the way. Don't provide all the data for the case one shot. Sometimes, as I mentioned, there is progressive nature. So day one, you have this problem. On day two, the patient developed another problem or updated maybe follow up from day one. So something new happened in day two. Later on day three, the patient stabilized. But on day five, something new happened, and maybe some abnormality or electrolyte abnormality, whatsoever happened in the case. So this progressive disclosure of data is critical actually to help building the critical thinking on the way, and also to maintain the collaborative learning going. Encourage peer-to-peer teaching, give the group time to work and to interact together. And the most important one, after answering all the session, must be some sort of debrief to consolidate what key points we can take from this case in general. Before I finish, I also maybe thought to share with you, if I want to use generative AI in case-based learning preparation, conduct, and delivery, this could be done easily, but it has to be done also responsibly. So first, you can decide, or you can create some sort of cases. If you want to ensure the cases maybe align with the clinical guidelines, align with the practice and all this one, it is very much advisable to start with one real case first and use this case as a template with the clinical guidelines and all the resources we have in practice, and give maybe the model of the AI the points or the resources to work on to create the case according to the template you get from the practice. And after this one, you have to revise all the details to ensure that everything in place and nothing actually maybe have been done hallucination and all this the common problem with AI. This will help sometimes to personalize, create personalized learning path. You can adjust on the way, adjust the case complexity, adjust maybe how you want branching of certain questions, want one questions to be divided in some other question as well. You can do this. You can do this. Sometimes also you can work on virtual patient simulation. Ask the chatbot interface to power by large language model to work on maybe stimulate as a patient pharmacist interaction. You can work on this one. You have few tools in the literature simulating this kind of interaction to provide some sort of practicing clinical reasoning and communication all together. Can also use to provide real-time feedback and assessment. This usually is maybe paramount. You get certain answer or you provide certain response, you want the feedback. So this kind of innocent corrective feedback should be or could be there. Also, you can use this one effectively to do continuous enhancement and improvement in the cases you create over time, and even on the assets you used in your session. And by the end, also it can help the facilitator to do some sort of content enhancement and create some multimedia asset as needed. So if I want to conclude at the end, I would say if I want to take main takeaway points today, I would say CPL is something makes learning active, and active learning is fundamental for pharmacy education, and the most important, clinically relevant. Clinically relevant. This very much important. You have the way to do some sort of structured framework to guide complex decision. So based on the design of itself, you can assess how efficiency and how the skills, the competency when it comes to take certain decision at a complex level. As a pharmacist, of course, working together, work with other healthcare professionals, understanding maybe the rules and boundaries is maybe fundamental. So teaching around the multidisciplinary solutions and how the collaborative practice and collaborative learning will help. This could be one of excellent point. Like case-based learning, actually one of the excellent platform to implement interprofessional learning. We have some session here. We get students from nursing, students from pharmacy, medics, and all together work on the same case from different aspects. So this could be a good point to look and consider. Continual reflection and evidence update will be essential. This may be you implement one session and you get some feedback. This feedback will refine the case for the next offering and refine the case for a next group, and perhaps adding on this certain case to be utilized in different level. This all can be done in a continuous improvement cycle. At the end, I think this could be the key references if you are interested to get more about the case-based learning in pharmacy education and practice. This is the first, and then the meta-analysis and some other interesting and relevant resources as well. I think that's all from me. Back to you. And if you have any questions, if anything you want before we conclude the session, would be much appreciated. It is your time. If you have any questions, anything you want to ask, this is my email for any maybe professional contact later on. You are most welcome.
Yes, sir. Thank you. And if you can ask any questions, please unmute yourself and you can ask to sir directly, or you can put your questions in the chat box.
I think it seems to be no more questions. I'm very mindful. I want to actually to give you some, perhaps maybe little break time before your next session. I understand you have next session after 5 minutes. So if there is no further questions, I am back to moderator, and you are free if you want to give the attendees some break time before the next session. Thank you so much.
So we do have a question. What are the most common reasons behind DOAC dosing errors in clinical settings?
Yes, of course. I think is overlooking sometimes the monitoring on the go. I think the patient's starting point will be at certain clinical condition over time, and we know that DWAC sometimes it is used on chronic basis, especially for certain indication like the AF and all this one. And the patient condition change, and the dosing does not change. And sometimes at the same time, the patient condition when it comes to renal function change. And sometimes the patient start to take other medication that contribute to the risk of bleeding without acknowledging that maybe the direct impact in this particular scenario. So I think the most common will be changing the patient condition over time. And the second one will be the co-administered drugs. Should pharmacists be given more authority in initiating or adjusting anticoagulation? Of course, I think what I have seen in Malaysia, and it is already implemented here as well, we have anticoagulant clinic run by pharmacists to have some sort of comprehensive evaluation of all related to anticoagulant therapy. So looking at the patient history at the very big picture first, because sometimes even what the patient consume as foods and all this one can have certain impact. So I think the pharmacist in many settings should have maybe some kind of authority or clinic to look in a comprehensive way after the anticoagulant, initiating, adjusting, and monitoring and follow up on a chronic basis. Yes, it's very, how effective are pharmacist-led anticoagulant clinic in reducing adverse drug events? I think this kind of, we have now in the literature actually evidence that show this kind of clinic, dedicated anticoagulant clinic, have been effective in terms of reducing the overall adverse drug event or reducing problem and ensuring safety with using DWAC and warfarin on the long term. We have evidence. Of course, the evidence is based on maybe certain settings like maybe the US, UK, and maybe some other places. But again, we as a pharmacist, we share common traits and common problem and common challenges and common practice everywhere. So when it works in certain country, I think it can be replicable and can be offered and replicated in another setting, provided the support or the system support is already in place. As I mentioned, this is a collaborative one. So the pharmacist-led clinic, for example, you cannot lead a clinic on your own. This clinic should be in coordination with others. What is the role of actually here there is no PharmD in the UK. The UK we have MPharm, we have MPharm program. When you finish the MPharm, you can maybe go for community hospital whatsoever. Every sector you have maybe a certain task. I think more or less will be similar to the hospital pharmacy in setting, looking inpatients and looking some dedicated role in certain ward, for example, looking after pain, looking after critical care, looking after this here and there in hospital setting. I think it will be again like the hospital pharmacy role in general. But the PharmD as a PharmD is not actually here in the UK as a degree.
And one more question, sir. If you could tell us about the license, how to apply for license in UK.
Oh yeah, I think this will be applied to the any international pharmacy graduate to work or to practice as a pharmacist in the UK. I think right now it is more into you get some sort of additional study for a year. This actually will be programmed under one of the accredited university. And after this one, after you finish this year of study, you will be asked to do some sort of attachment and training. And by the end, you will undertake an exam, and that's all. But of course, maybe to be honest as well, this study and this attachment, and of course, will be costly for international graduate. So, but the details and everything are there. Yeah, it is a kind of study and then attachment and then exam. But of course, this kind of costly for those people does not have any support mechanism or strong support mechanism within the UK or even funding from outside. How reliable? Yes, perfect. I like this question. How reliable is AI-generated patient data in preparing clinical scenarios? Of course, as I mentioned, if you will be using this one to generate clinical scenarios. So my advice is two main advice. The first, don't ask, maybe it is all related to the prompt you ask the model or you ask the AI to generate. So give the as much details as you can. So give all the details you want. For example, what kind of references you have, what kind of questions you have, what kind of data you have, you want them to generate. The most important, while giving very extensive clinical prompt, the second point, to attach some of the resources that you have. So we have understanding what actually you are looking to. So if certain, for example, you are creating case related to diabetes, so the latest guidelines on diabetes just maybe provide this one as a resource. So provide extensive prompt that highlight each and everything and provide the resource that the AI should work on. By this way, you will, to some extent, guarantee that you have near to what you want a content created by AI. But at last, for any AI generated content, it is your own responsibility to check back against the resources and against what have been intended to deliver to ensure that everything is in place. But what you can do prompting very effective and very clinical at the beginning, do attach the resources and the guidelines that you want to use, and at the end, revise critically the outcome coming from the AI at the case. Is the use of IC because we will provide much information? It depends, of course, on the privacy of the setting you have and the information you share with. If you have maybe certain policy or information related to say to give certain information or resources, of course, it is up to you and according to the organization I work on. But it depends. It depends. We're getting pharmacovigilance job. I'm not sure, to be honest, in the pharmacovigilance job, and I'm not sure about this one, so I cannot actually maybe make a comment. What are the roles and responsibility clinical pharmacist and PPS doctor, and how to do clinical pharmacy assistant? Clinical pharmacy, of course, it is integrated in the care in the hospital setting here, and it is offered for as a progress for hospital pharmacy within certain places. We have here some specialty related, of course, as everywhere, a specialty designed for the clinical care for patients. So, for example, the hematology oncology will have two clinical pharmacists looking after all patients. The same with the medical ward for the same with the cardiology, for example, the same. So based on the specialty, and this actually done, or most of the time will be in a collaborative professional relationship to assist and doctor. When mainly anything related to medicine will be somehow double checked by the pharmacist before it has been approved to the patient, and sometimes even has to undergo the pharmacist to approve and check before it is finally prescribed to patient. Okay, hope this one give a bit of overview what actually clinical pharmacy can do here. So specialty based and maybe collaborative professional relationship. I hope that answers everything.
Yes,
You are
sir,
welcome
definitely.
you are welcome anytime. If you want to have certain query or certain stuff you want to ask, you can email me anytime. Thank you so much.
Thank you so much, sir. That was really wonderful. And the thought process behind the topic was really appreciated. And I could definitely see how impactful it would be if applied in the healthcare system and in the education field. Thank you so much for giving your valuable time and coming for us and explaining each and everything for us so crystal clear. Thank you so much, sir. We are really grateful to
Thank
have
you.
you.
Thank you. Thank you so much. Thank you. Bye bye.